We're so excited to welcome you all to another inspirational and educational episode of Concorde Conversations. Concorde Conversations is an initiative by Concorde Medical Group to educate, empower, and encourage our community about our health so we can all live to our fullest potential. In today's episode, Orthopedic Treatments of Tomorrow, today, we're talking about the fascinating and innovative field of regenerative orthopedic medicine. Hi, I'm Dr. Catherine Weinberg, Director of the Adult Congenital Heart Disease Program at Northwell Health, and we're joined by a pioneer in the field, Dr. Ken Zaslav. He is the Director for the Center of Regenerative Orthopedic Medicine, Professor at the Zucker School of Medicine at Hofstra University, and Co-Chair of the Biologic Association. He's also the past President of the International Cartilage Repair and Joint Preservation Society in Switzerland. Many of you have asked fascinating questions for us to ask our expert today. If you have any additional questions, please ask them in the chat box. We only have 30 minutes together, so we're going to go through as many as we can. Remember, we're giving general guidance. So if you have a particular question about your health, we'd like to help you. So come in to see one of our exceptional Northwell physicians so we can answer your questions and give your health the attention it deserves. Thank you so much for joining us today, Dr. Zaslav. Would you like to tell us a little bit about your history and how you started in the field of regenerative medicine?
Sure. I started practicing a long time ago, 1990. I trained here at Lenox Hill in NYU, and then went down to Richmond, Virginia, where I was in practice for 30 years. We started with a 4-man group and grew to about 100 over a period of 30 years. And my wife and I decided we'd love to come back to New York, and I was given the opportunity to come here and become the director for this new Center for Regenerative Orthopedic Medicine and continue as a sports medicine specialist at the place I originally trained. Somewhere around 1996, this area really began in the orthopedic space when a Swedish researcher, Lars Peterson, who actually trained for a while at joint disease, which is now part of NYU, did some pioneering research on the first ability to take cells from a patient in their cartilage and grow it in the lab and retransplant new cartilage. And I did the first cartilage transplant in Virginia probably around 1996. His first paper was published in 1994. And then became a member of this new society based in Switzerland, which was all of the orthopedic surgeons, physical therapists, and scientists working on cartilage repair and early osteoarthritis throughout the world. And over time, I became very involved there and ultimately became the president of that organization about 6-7 years ago.
What is regenerative medicine and how are you applying it to orthopedics?
So in general, the term regenerative medicine talks about how we can use things from your body, things that your body makes itself through its own progenitor cells to try to heal disease or heal injury. And regenerative, is still a term we can't prove. That is, our hope is to prove over time that we can truly regenerate organs or regenerate tissues. And we have a few examples of that at certain very early work around the country with some cancer cures, as well as with some work for fistulas in the GI system. But in our area, in orthopedics, so far what we can say is we can mitigate symptoms, decrease inflammation, decrease pain, decrease swelling, and we hope someday to show regenerative capacity. But that truly hasn't been shown. And one of the problems with the internet is there's lots of people out there saying that they're regenerating when truly, at least in humans, that hasn't been proven yet. But what we're looking to do is take tissues from you without the use of medicines or surgery and treat these either acute or chronic injuries.
So your goal right now is to decrease pain and inflammation and try and preserve joints for as long as possible. So can it help someone with knee arthritis postpone a knee replacement?
Yes, so it does. We have no evidence that we can stop forever you not needing a knee replacement. However, we have a number of treatments which we can discuss today, which take tissues from you, whether it's from your blood or your bone marrow or your fat, and we can do minimal manipulation today. So what does that mean? It means that we can't send it to a lab and grow cells and do those types of things and transplant it back in you yet. That is not legal in the US. So the word stem cell is not really right. What we're doing is taking these tissues and either centrifuging them or putting them through small filters or chopping them up, and at the same day, in this new form that's been minimally modified, putting it back into your joints. And what we're doing is concentrating the factors that we think can benefit you, cytokines, growth factors, proteins that your body makes that can give you less inflammation and less pain, and therefore help you to live with your arthritis. Just like we treat diabetes, we don't cure it, we mitigate it, we keep the sugar normal. And here we're trying to decrease your symptoms so you can live with your problem. In addition, in some acute injuries, we found that early use of some of these injectables can quicken the healing rate.
Okay, so regenerative medicine is not stem cells. What are stem cells?
Well, stem cells will be used, we hope, someday in regenerative medicine, but it's currently not legal in the United States. Stem cells are progenitor cells from your body that can turn into multiple things. So of course, the major stem cell would be embryonic. We don't use those, but in the musculoskeletal space, you have a mesenchymal stem cell in your marrow, and this particular cell in the lab can turn into bone, muscle, tendon, cartilage, and fat. And if you take these cells out and grow them, you can, with all kinds of tricks in the lab, turn them into all those tissues. But what we have learned is when you take them out of your body and prepare them and then inject them back into you, they don't actually act as stem cells. They don't become anything. They go in like a little pharmacy, and they bring this pharmacy of knowledge and proteins and cytokines that then teach your own body what to do in that area and make that organ or that joint, in our case, more homeopathic, more normal equilibrium. So we don't think they actually act like a stem. So we've changed the word of MSC, mesenchymal stem cell. We mostly call them medicinal signaling cells. And we think that's the future. And they put off these little things called exosomes, which tell your cells what to do.
It's pretty amazing. So what is joint preservation, and what can you do for someone who has injury to their cartilage?
So in the old days, when you would injure your articular cartilage, if you break your bone or I cut your skin, like in an incision, new skin cells form, new bone cells form. But when you break articular cartilage in an adult, the cartilage does not replicate, and it has a very poor blood supply, and it doesn't fill in with normal tissue. So it has no ability to heal itself. So for many years, what happens is over time, the broken cells release more enzymes, and you slowly increase the area of wearing. And then you can also mechanically wear the other side as the rough surface hits the smooth surface. And so eventually, these cartilage injuries often can turn into osteoarthritis. Starting in '96, we started to find ways to repair these tissues and try to avoid the onset of osteoarthritis. And we've done that with a number of ways. So joint preserving surgery is surgery that we do to maintain your joint rather than replace it. So everyone knows about joint replacements, very successful with metal and plastic, very good results, but they don't last forever. And for young patients, they're not the best option. So now, rather than tell people to just take aspirin or Aleve for 20 years while they wait for their joint, we can do surgical treatments to actually preserve the joint. Those can be anywhere from taking cells from your own body and growing them in a lab in Boston, and then they come back to us and we can retransplant those cartilage cells into your defect. We also have the ability to take a donor. So someone under 40 dies and they donate their heart and lungs for immediate transplant, but their knees can be stored in a cold storage for 20 days while we make sure there's no infection or a viral or bacterial infection. And if there isn't, and we find the match size-wise, we can take a piece of bone and cartilage from that patient and put that into your defect and have an immediate transplant with full cartilage. When you do the cell transplant, of course, you're asking the cells to regrow new cartilage. Takes a bit more time. And now we just finished some incredible work with an Israeli company over the past 13 years and just got the first FDA approval for a new product that's an acellular off-the-shelf implant that can go into your knee in the area where there's no cartilage or cartilage injury, even in patients with early arthritis, and we can grow new cartilage. This implant, amazingly, is made from sea coral. And the bottom third of the two-thirds of the sea coral is just plain coral, which we've always known looks like bone under the electron microscope. So it always helped heal bone. But by modifying it with little drill holes on the top third, we can stimulate chondrocytes or cartilage cells to grow as well. And that was just approved, and we should start doing those, I think, in the summer of this year in the United States. They've been done in Israel and Europe for the past 2 years. So lots of options to try to preserve joints as well. You have to make sure that the ligament is fixed, or the meniscus, if it's torn, has been replaced, and make sure your knee is well aligned. All of these things matter to the organ, but that's what joint preservation is all about: preserving your original joint, getting new growth, and trying to slow or prevent the onset of osteoarthritis.
So can these technologies reverse osteoarthritis, or at
Well,
least slow them down?
there's two different things. Let's talk first about those patients who have cartilage defects. Yes, we have evidence that we can have 20-year good results and slow down any ability for it to wear away. Someday you still may need a joint replacement if other parts of your joint wear out, but those have been very successful in if those that work, for instance, at 2 years, if you follow them for 20 years, they still have good to excellent results in 90% of patients.
Wow.
Now, a separate issue is for patients with arthritis that are too far gone for these surgical treatments. These injectables we are talking about, those could be platelet-rich plasma, PRP, or lipogems, which is taking fat from your flank and taking these fat and running it through special filters, getting rid of the greasy part and concentrating the liposomes and MSCs and injecting that in to your joints, or taking bone marrow and concentrating it and putting it in your joints. All those, what we call ortho-biologic injections, they have been shown to mitigate symptoms. We hope to prove they can slow the arthritic wear. We have no evidence that they can reverse it. So it's really not true that they regenerate at this time. We are hoping over time that we hone in on what is important in these structures we're putting in and do real studies like we would with new drugs or new procedures, and prove that over time, if we really enhance these and get the correct exosomes or the correct proteins that matter, that we could find a way to actually regenerate your joints, like salamanders do. When a salamander loses a leg, the epiglottal, the part that has the stem cells in their limb just regrows a new limb. We hope someday to be able to do that. That is not possible at this time.
Are these therapies only for chronic pain like arthritis, or can you use them for more acute injuries like a tendonitis?
Well, acute tendonitis we will always treat with anti-inflammatories and aggressive physical therapy, and that's very, very, very effective in most patients, probably 85%. Some people, though, have these chronic recurrent tendinopathies, and studies have shown that if you look under the microscope at these patients whose tendons are not healing and not improving, that this tendinosis occurs where there's an actual change in the cells. They're not replicating appropriately. And we have found that if we stimulate these with little needle injections and PRP or bone marrow aspirate, that we can re-stimulate healing in the chronic tendinopathies, patients who are not responding to physical therapy, rest, and anti-inflammatory.
Okay. So if a patient presents to you with knee pain, do you use a cortisone injection, a gel shot, or do you go straight to PRP?
That's a great question. We use all of those things. So if someone has basically been fine for years and they suddenly banged their knee or twisted and they have an acute injury and they have some swelling, we'll often remove that swelling and place cortisone just to reinstate the normal homeostasis of the joint and stop the inflammatory reaction. That can be really successful. What we don't like to do is repetitive cortisone injections. So if that works, but every 6 weeks it's coming back, then it's not healthy to use that. But for a first-time injection, it's very, very successful, and we use it a lot. On the other hand, for more chronic arthritis, patients who will need regular treatment like a diabetic, we want to keep them pain-free for a longer period of time. We can use the gel shots, which are really hyaluronic acid. It's a thick, viscous protein from rooster combs or bacterial fermentation that acts to thicken the molecular weight of the fluid in your knee. So it gives it more viscosity, the ability to withstand load in a water system or a liquid system where you have less cartilage, and it's an anti-inflammatory like cortisone, but it's homeopathic and safe. And it lasts 6 to 9 months, so we can do those injections. But if you look at all the studies comparing cortisone to gel shots to PRP, the best results are with platelet-rich plasma or PRP to date. There's at least 50 randomized controlled trials and several systematic reviews that show this. However, The gel shots and the cortisone are often covered by most people's insurance, whereas all of these ortho-biologic things we've talked about, the fat, the bone marrow, the blood, or the PRP, all of those are still considered investigational. Patients should be followed by their physician with patient-reported outcomes to prove what we're doing, and they are not covered by any insurance, so they're a cash outlay.
Is everyone's PRP the same? Does everyone react the same?
That's both of those questions are good ones. So first of all, everyone's PRP is not the same. So even for you yourself, Dr. Weinberg, if I took your blood today and then I took it 7 days from now from a different limb, you can have different proteins circulating at any moment in time. So we're actually doing research right now here at Northwell, along with 7 other centers, the Mayo Clinic, the Cleveland Clinic, HSS, Cedars-Sinai, and Colorado University, all the top places in the country now doing biologics. We've joined together to look at large volumes of PRP patients, have them taking patient-reported outcomes, but also at the time of injection, we're taking a little aliquot of the PRP and not putting it in the joint and storing it in a freezer. And ultimately, we're going to do analysis of these PRPs to see what was in them at the time. And hopefully after we have 2,000 or many, many patients in these registries, we can see, are there common proteins that when you have them in your blood, you become a responder, you do well. Because about 80% of people respond to these treatments, 20% of people don't respond. We don't know what makes them a responder. So A, what's in your PRP varies. B, the way your body responds to that PRP may vary depending on what's in your blood at the time. And then lastly, there are at least 7 to 10 machines out there in the United States that have been approved by the FDA for PRP production. And every one of these is different. They give a different amount of white cells. They give a different amount of platelet-rich concentration. So for instance, sometimes you're concentrating the platelets 2 times, sometimes 7 times to 10 times. And we don't know yet which dosing is perfect. So again, a lot of unknowns. We have great data that this helps a large number of people, but we have a lot to learn on how to maximize its effect for everybody and figure out who will be the best patients to get, so we have true individualized medicine for patients over time.
So it's really important to go to a center where they do a lot of this, where they're doing research, correct?
I think so. I think a lot of people are doing these injections, charging very, very large numbers, and are not following patients or are not really following any specific protocol. Patients who are in pain, of course, are often willing to pay anything to get out of pain. And so I think, looking for one of these centers where people are doing the research, following the patients, giving you the real facts, not giving you hype, but true hope and facts and reality, I think is important. And that's one of the things that the FDA and the FTC, the Trade Commission, are now looking at people's websites and looking at things on the internet to try to get rid of people who are making false claims. For instance, nobody can be claiming that these things they've not been approved for treatment for arthritis or for any specific disease. A doctor can try it with you and say there may be a benefit, but they've not been approved for that use by the FDA. So it's legal to use, but they're still considered investigational.
There's a couple questions in the chat box about insurance coverage. Can you just specify what's usually covered?
Cortisone is covered. All of the surgical treatments I told you about, as long as you're an appropriate candidate that has the correct pre-existing conditions and the correct diagnoses and tests, all of those are covered by most insurances. The only thing and cortisone is covered, and so is gel shots by most insurances. Now, not every. There are some insurances in the US based on some studies that show that the HA injections, the gel shots, are not that much better than placebo in some studies. So some insurance companies use that to stop paying. But I'd say about 75% of those in New York and New Jersey still pay for it. However, the PRP, fat, and bone marrow injections, all of the ortho-biologics are not covered by any insurance.
There's a question in the chat box about how do you determine who is an appropriate candidate for these ortho-biologics to delay a total knee replacement?
So patients who, for instance, can't have a replacement because they have some other medical problem, or they just feel they're too young and they're not ready, or for work reasons, all of them are candidates. The only patients that we believe are too far gone for these to really make a difference are those that have what we call Kellgren-Lawrence 4 arthritis. So that means that on the x-ray, it's totally bone on bone. There's no space left. The results are not as good with those patients as they are with KL 1, 2, and 3, which are lesser degrees. Some change on x-ray or no change, but some change, but not complete bone on bone. So once you're all the way down, you have malalignment, you have severe bone on bone arthritis. These are not as helpful. They won't hurt you, but they're not going to be as helpful.
Okay.
However, for our KL 1 through 3 patients where there's still some space, you're an active person, we do this along, as you know, Dr. Weinberg, with other treatments, because this is not done on its own.
Got it. Okay, besides the knee, what other joints can you use orthobiologics on?
Ortho-biologics can be used on any joint that has inflammation or arthritis or injury. So we use it in the hip, we use it in the shoulder, we can use it for tendinopathies, for instance, patellar tendonitis that's chronic, rotator cuff tendonitis that's chronic. All of these have been studied and used. The most common is the knee, but it can be used in almost any joint. There is some early use now in the spine. It's got to really be done by pain or spine specialists who can inject under x-ray guidance. And that's the earliest, that's the area with the least amount of data. And we don't know how the long-term data on those spines will work. But for shoulder, knee, hand, wrist, all of these have been used, and ankle, of course, as well.
Okay, there's another question in the chat box about mild anterior labrum degeneration. Is that someone who's a candidate for these types of procedures?
Is this in the hip we're talking about, or the shoulder?
Doesn't say.
My guess is it's in the hip, because it's so common. People that have hip impingement and have a small partial tear of the labrum. We have used PRP injection with some success. Yes, it does not reverse or heal the labrum, but it can give symptomatic relief.
Got it. Would you like to talk about some of the research that you're doing at the center?
We have several clinical studies going. One was with amniotic fluid, which we think is a real future. For years, there was an amniotic injection on the market. When the FDA decided to start regulating ortho-biologics from your body, they decided, look, blood, fat, bone marrow, you're just putting it in a centrifuge or a filter. That's minimal manipulation. That you can do. But mothers can donate the amnion, the chorion, and the amniotic fluid from a live birth. We're not talking about embryonic. This is amniotic. So they donate these tissues from live births, and that goes to a drug company, which then purifies it and make sure it's sterile and clean, and you can then inject that into the knee. That has had great results. We were part of a multi-center study 5 years ago, which was reported in the knee journal as well as in the arthroscopy journal, with excellent results comparing amniotic fluid with HA injection or cortisone injection and with placebo. But the FDA decided, look, this is more like a drug, so we want a full randomized controlled trial again under FDA control. That study has occurred and has now been completed. We should have the data in about a year, and they want a second study, which is beginning now. So we are part of these centers that are doing these amniotic studies. In addition, we're starting a study with the company that does the lipogems, the fat, to get true FDA approval for an osteoarthritis indication. So we're comparing patients who have the fat taken and have fat injected with a blinded syringe. Some people have cortisone injected, and we're comparing. And that study should start in about 2 months. We hope to be doing some other arthritis studies as well in the future. In the lab, we're working on very exciting stuff, which is not ready for prime time in humans yet. But we believe that the way MSCs or mesenchymal signaling cells or stem cells work is they put out these little exosomes. Those are very, very small particles with mRNA and DNA and proteins that can penetrate your cells and teach them what to do. And these exosomes are much easier to store and keep someday than stem cells themselves. And they has less reactivity. So you don't have to do HLA or typing. You can donate someone else's. So we are working now in mouse and sheep and rabbit studies using exosomes for treatment of arthritis and other things. And we hope to, and there's some other research going around at the Mayo Clinic and down at MD Anderson utilizing these exosomes. And I think that's going to be a real future. So we're working on that in the lab. And at Feinstein, which is part of Northwell, we have several PhDs and master's students working with us on these studies.
It's amazing what you're working on and all the hope for these regenerative medicines, whether in orthopedics or cardiology, is just amazing.
Yeah, cardiology, as you know, is way ahead of us, and they've been doing this work for quite a while. And in fact, the GI tract as well and wound healing have seen great results with MSCs at this time.
Yeah. So we're going to wrap up. So our last question, if you had one action step to recommend to our viewers and start today to improve their health, what would it be?
Well, as I said earlier, I guess when we talked the other day, when you do these injections, I also encourage everybody to do strength training and aerobic activity. And because that's really important to have the power to stabilize these joints and to maintain your fitness and your general health and to keep your weight down. Every pound you gain is 4 pounds of force on the knee or hip. So we are big believers, if you have to do one thing, is to maintain activity, walk, cycle, swim, low impact activities, very helpful, and strength training for your quads, your core, and your glutes, very important to help stabilize these arthritic joints. So that would be my one hint to have a better life if I had to pick one thing to do.
Well, I can endorse all of those things as a cardiologist as well. So thank you everyone for joining us for another inspirational and educational episode of Concorde Conversations. A very special thank you to Dr. Zaslav for joining our conversation. We appreciate his expertise to educate, encourage, and empower our community. As part of the community, we hope you'll share in our mission. Please pass along our emails and webinar links to your friends and family. In addition, please subscribe to our YouTube channel. We know you have additional questions about your health and we want to help you. So come in and speak to our extraordinary Northwell Health physicians about your health. We care about your health. We care about you. Thank you so much for joining us, and we'll see you next month.
Thanks so much, Dr. Weinberg. Great talking to you.